I'm Matt Broderick. I'm an HCPC registered podiatrist. I've been asked to do a talk for LFE, the League Football Education for 83 clubs across the UK. Today I've been asked to speak to you about compartment syndrome. So compartment syndrome, as I'm sure you're all aware, is when muscles swell within a fascia. So muscles, nerves and blood vessels are all constricted within a fascia. Compartment syndrome occurs where basically there's a tourniquet effect of that fascia around the mentioned structures. So to talk about the signs and symptoms of compartment syndrome, 95% of cases of compartment syndrome present in the lower limb. There are the odd occasions and the odd athletes that are predisposed to compartment syndrome in the upper limb, such as rowers, motorcyclists as well, due to the repetitive nature of their sports. So compartment syndrome, signs and symptoms. Paresthesia, so numbness and tingling sensation in the feet and in the calves is often something that comes along with compartment syndrome due to the entrapment of the nerves. A change in colour, so you'll notice a difference in colour between the symptomatic side and the asymptomatic side. And it will obviously be very painful and very tender to the touch. So compartment syndrome, it can be limb threatening and it can also be life threatening, so it's a really important diagnosis to consider when looking at the lower limb. An alternative diagnosis for compartment syndrome would be shin splints. So there are two types of shin splints. Medial tibial stress syndrome, which affects the medial side of the shin, so just along this side of the tibia. Pain is often experienced just on the inside of the calf. Predominantly, it gets worse after a run. Many different theories as to why that occurs. The other form of shin splints is anterior shin splints. So the muscle involved in this form of shin splints is the tibialis anterior that runs along the front of the shin, starts at the tibial condyle, inserts into the medial cuneiform and into the first metatarsal. That's due to an overload of that muscle due to various different reasons. So it could be a leg length difference, it could be increased pronation, navicular drop to be precise. All of those can be treated if you go and have a chat with your podiatrist. A set of orthotics can usually be very beneficial in treating that condition. So compartment syndrome, it's, as I mentioned, it can be a limb-threatening and life-threatening condition. So differentiating between that and shin splints is really important. So to test for shin splints, often palpating along the front, so just having a good old push around at the front of the shin, that will be very, very tender with someone with shin splints. Additionally, testing their dorsiflexor muscle. So if I just ask John to push upwards now against my hand, you can see the tibialis anterior firing. That will be very sensitive in someone with anterior shin splints. Compartment syndrome, however, is very, very painful during exercise due to the swelling of the muscle and the constricting, the tourniquet effect of the fascia around the muscle. So getting a detailed history from your patient is probably paramount, or is definitely paramount in diagnosing this condition. In terms of treatment, as I mentioned, podiatrists can come very much in handy with orthotics in treating this, particularly if it's mechanically related. In terms of treating a severe case of compartment syndrome, surgery is mainly the only option really. A fasciectomy can be carried out, which is when the fascia is released, so releasing the pressure within the compartment and allowing the muscles to function as per they usually would. So it's one to watch out for in terms of the lower limb. So as per the video, I mentioned that the biomechanics of the foot and the lower limb can influence whether someone develops compartment syndrome and shin splints. So shin splints can be developed as a result of someone who pronates past mid-stance. So pronation is something that should happen. It's a shock absorber, but when it happens for too long in the gait cycle, that's when it can become problematic. As per I mentioned earlier, the insertion of the tibialis anterior is on the cuneiform, and that bone drops as we pronate, so it stresses that muscle. And as you can appreciate, lots of this can be sought from just clinically testing the patient, but in the 21st century, we've got other bits of tech that can also help us. So this is the results of a pressure plate, and this is someone just stood still. We can see the pressure maps at the bottom of their feet. This person is very pronated, so you can see there's a clear imprint of where the arch is not being held up, the foot's completely flat. So this person would be at risk of developing shin issues and many other issues. Additionally, you can see there might be a difference in leg length. As I referenced earlier, that can also put you at risk of developing compartment syndrome and other issues like shin splints. So that the right heel is a hot spot at the right heel, meaning that she's putting a lot more weight through her right foot. So maybe the left leg's a little bit short, which is something, again, that could put her at risk of developing that. So previously that was a static analysis of the person's pressure in the bottom of their feet. This is a dynamic analysis. So a lot of the time, the foot reacts very differently when you're walking compared to how you stood still. So you can't always take all that much from a static assessment. You've got to look at someone walking as well. So gait analysis is a way you can assess what's going on in the lower limb and how the lower limb moves. We can also look at the pressures beneath the feet. So this is the patient walking just in a straight line. As you can see, what was found in the static analysis is true in this case in the patient. She is very, very flat-footed. So as mentioned, that is something to watch out for.
Hi, John Rothery, Osteopath. Thanks for allowing me to talk about hernias today. I know some of your students are covering this as part of your LFE, League Football Education, and there are many different types of hernias. There's umbilical hernias around the tummy button, there's hiatal, there's epigastric, but the most common one we find in private practice is inguinal, which is the inguinal ligament down here in the groin. Often patients present with pain or protrusion of the abdominal contents. When they stand up, it seems worse, and that's because the abdominal contents descend under gravity, and when they lie flat, it feels better. What you tend to find is if it's really bad and the patient lies down, they can actually push it back in, but it depends how big the herniation is. If it's a big herniation, and say they've pushed or strained quite aggressively, they might also be suffering from fever and chills and suffer from nausea. And if that's the case, then you need to get medical emergency. What they do is they put a mesh-like tissue around the hernia to stop the abdominal contents or the diaphragm protruding through the skin. And quite often you see in private practice, lots of people have had especially inguinal surgery. There is another hernia that we talk about a lot, is sportsman's hernia. It's not actually a herniation where the diaphragm or the abdominal contents protrude through the skin. It's actually in the pubic symphysis here, especially in footballers where they do lots of repetitive strain, they've got tight groins, tight hamstrings or repetitive groin injuries. What they tend to do is, if you sit up for me, Matthew, keep your legs straight, they tend to report getting pain deep into bilateral areas of the groin. And that's what's called a sportsman's hernia, which, even though you use the word hernia, it's not a hernia in its true sense. It's just micro tears of the adductor tendons, or where the adductor and hamstring insert into the pubic symphysis. So with hernias, often you need medical help, and sometimes you need surgery. So it's not a case of where you can treat it. You can, after, loosen off the hamstrings and stuff like that, but generally it needs medical assistance. So that's the different types of hernias. Thank you. Oh, hi, I'm John Rothery, registered osteopath. I've been asked to produce some videos for the LFE, which is the League Football Education, and we're going to look at today what's called knee bursitis. There's 14 bursas in the knee, and today we're going to look at 5. So I'm just going to quickly give you an anatomy lesson. So there's patella, or the kneecap, and there is a bursa which sits under here, which reduces the friction between the knee and the skin and the tissue and the fascia. And we call that prepatellar bursa. There's also a bursa here, which we call the infra, which means underneath, or infrapatellar bursa, which is where the tibial tuberosity occurs. It's quite common in this area to get inflammation as a child in what we call Osgood-Schlatter disease. Here we've got a bursa which is above the kneecap, which we call the suprapatellar bursa, which just sits here above the kneecap. We've also got the back of the knee. We've got where the gastrocs or the calves insert. You can get gastrocnemius or calf bursitis. And you also can get what's called pes ansinine bursitis, which is basically on the medial aspect here, where the sartorius gracilis and semitendinosus occurs. There's kind of the main etiology of a knee bursitis in a footballer is direct trauma. So if they land on the knee aggressively, that can cause an instantaneous bursitis or a swelling. Or if, for example, like Matthew, the podiatrist, he talked about, if there's a leg length discrepancy or the foot's pronated, that can cause repetitive trauma over time, which can cause the sacs of fluid to swell. So what happens with the signs and symptoms? You normally look at the knee, it'd be quite warm, it'd be swollen. If it's a prepatellar bursitis, it can look like an egg on top of the knee. It's like an egg shape, and it can be quite swollen. Sometimes it might need to be aspired or by a surgeon, so they remove it. If it's infected, say you're playing on some astroturf and you've got some infection through a graze, then you have to be given a course of antibiotics. That's another way of getting a bursa. So what we tend to do, if it's just an overuse injury or traumatic rest, ice, compression, elevate for the first 24 hours. And then post-acute injury, then we try and reduce the swelling by doing some gentle mobilization and some swimming exercises with your physio. What you would tend to find is, if it is sort of infrapatellar here or prepatellar here, when you flex the knee, you tend to find the patient gets pain and it's normally red and swollen. So we rest. What you can do is, because the hamstrings insert into here, if the patient has, just relax your leg, Matt. Say for example, keep it straight. If they've got tight hamstrings like Matt has, if you work on the hamstrings, that can reduce the stress around the area, or tight calves. So we tend to, if it's infected, antibiotics. If it's non-infectional and it's traumatic, we tend to do rest, ice compression, elevation, and then obviously gradually strengthening. If it's not responding to that, you can have a bursectomy where they actually remove the fluid from a surgeon. So that's bursitis, what we see in clinic as an osteopath. Thank you.